Hey, OncoPT, and welcome to this episode of the OncoPT podcast. Now, I don't know who signed off on allowing 2023 to accelerate progressively over the year and eventually reach warp speed, but like it or not, 2024 is almost here. And while I'm not quite ready for that yet, I did want to take a moment to just acknowledge and celebrate the passing of another year and all of the progress that we've made as a cancer rehab community. And so to do so, here on the OncoPT podcast, we are kicking off our end of year wrap up episodes where I have pulled some of the absolute golden nuggets from different interviews that I've conducted over the past year and put them together to ultimately create a episode that looks back and celebrates some of the hard work that we've been doing as a community, but also gives us some guidance on what we can continue to do moving forward into the new year. So this first episode is all about collaboration. Now I know I have even started hearing the word collaboration and there's like a mini cringe or like an eye roll that I feel like I default to. And here's why. So hear me out. I think that collaboration is a really loaded buzz phrase. And the idea of collaboration is really exciting and very necessary in healthcare, especially cancer rehab, right? But the actual reality of collaboration is, I think, honestly, like it's a myth a lot of times. There's a lot of reasons that this happens. There's a whole thing we could get into. But what I want to do instead for this episode, instead of like commiserating on, collaboration is so great, but like show me where it's actually happening, I'm not going to just say that. We're actually going to get into some other cancer rehab professionals and other physical therapists who are very much making collaboration a reality in their own practices and how they're seeing that manifest in patient care that is better, but also increased job satisfaction. And I don't know about you, I got into PT to help people, but I also know that like when I know that I did a good job at the end of the day, that makes me a more healthy, productive, just generally more pleasant human being to be around. So it is not selfish to want to feel like I want to know that I'm doing good things. I want to know that I'm actually helping people. And so again, this episode is a great zoom in view on some of the ways that different physical therapists and other professionals we've had on the OncoPT podcast over the last year are truly leaning into collaboration and making it happen. Not just, let's do a one-off kind of collab. Let's hope that it works. No, friend. I'm talking sustainable collaboration that benefits the patients, the community, and the healthcare team as a whole. So to get started, I don't know a better way than to invite back onto the podcast our dear good friend, Dr. Rebecca Seagraves. Now, you may remember her from episode 271, where we talked all about pelvic health, but also a lot of postpartum stuff. And I even opened the episode with, I have been avoiding this topic for a long time because I didn't really know what to do about it. Despite the fact that most of my patients, I think probably like 85% of my patients right now are moms. As in they have done the pregnancy and the childbirth situation, and we are now in the time frame after that. And while I could talk myself in and out and around of all the postpartum issues that these patients can experience, I'm actually going to zip my lips and let Dr. Rebecca Seagraves talk about how she is leveraging collaboration in her own practice and ultimately how that puts the patient back at the core of everything we're doing, which you and I would probably agree with is very, very necessary, especially today in healthcare. Take a listen.
And so once we actually stop and pause and say, oh, you're having this issue, this issue, this issue, this issue, well, I can absolutely form a plan around that, but I'm going to have to pull in some team members, or I'm going to have a
Mm-hmm.
discussion with your OBGYN, or we're going to
Mm-hmm.
have to start looking at this aspect of your function and maybe make some changes here. And so then
Mm-hmm.
you start actually pulling yourself out. And I talk about this a lot on a high level with pelvic health therapists specifically. I'm having them pull themselves out of their practice so that they can start forming a team that takes on more things than they're able to do. And I say
Mm-hmm.
that for orthopedic therapists all the time. I say that to acute care therapists. I say that to oncology therapists, is that you're not going to be able to do it all. But if you continue to talk yourself out of even walking into the room, then you're then taking yourself completely off of the team. And that person
Mhm.
needs a team more than anything. We're worried about the treatment. No, they need a team because they're going to deliver that baby eventually.
Mhm.
We're hoping that what we can do is have them work towards a successful delivery, but we also know that if they're starting treatment, there's a high likelihood that they could also lose their baby.
Yeah.
So we don't take ourselves off the team, not at any point. When they walk into our office, when they make an appointment, we stay on their team because they're going to need support postpartum, no matter what. They have a baby that goes home with them, or if they don't. And that's the recovery aspect because we know with cancer, their treatment will likely continue throughout their postpartum journey. So when
Mhm.
we're asking specifically, what do we treat? I can only answer that by saying we have to have a conversation. What is
Mhm.
it they're experiencing? And if it's pelvic girdle pain, absolutely. Let's find something that helps them stay mobile or give them the support if that's the right type of treatment.
Mhm.
If they're having shoulder neck pain because they're not moving their body and they're not really benefiting from joint impactful of reaction forces because they're not walking, they're not being active, well, then let's do something that helps them get into a better position. Can they get into the
Mhm.
pool or are they immunocompromised? It's all these things that we just have to then start using our physical therapy experience and
Mhm.
work with that patient through.
We wouldn't expect our patients with cancer to go to one oncologist and be done, right? You know, they my patients are seeing a medical oncologist who's managing the chemotherapy, immunotherapy side of things, et cetera, right? We have, of course, our surgical oncologist, we have our radiation oncologist, and like that's not even all that they see. We know these patients are seeing a lot of specialists. So this changing in kind of the framework with which we approach these patients, I think is really, really important that Rebecca is saying of like, we're on a team. And even not just I, as the OncoPT, am on the oncology team, but we have this team of even rehab specialists who are showing up for this patient consistently. I mean, talk about kind of a paradigm shift from what I think a lot of the reality of OncoPT tends to be, right?
Oh, absolutely. At least you're like dropping so I hope your audience is really listening to what you're saying, the response that you're saying, the questions that you're like, actually posing because it's so important. When I was in practice, there was a rule that a patient couldn't see an occupational therapist and a physical therapist at the same time in outpatient oncology if the diagnosis was the same. Fair, right? Insurance was not going to
Okay.
pay for
Okay.
lymphedema therapy by an OT under their plan of care and a PT under their plan of care. Didn't make sense. And so what we had to do is we had to be creative because we know occupational therapists focus on transitions to new routines and roles, which is especially important if you've just been diagnosed with cancer.
Mm-hmm.
You now have to adapt to a new routine and possibly a new role if you're also pregnant. And so an occupational therapist definitely needed to be on the team. If I, as a physical therapist, was really focused on the musculoskeletal function, guess what they were doing? They were focused on the daily activities, the mental health aspect, the medication management that this person now had, the appointments that they now had, the shift in their work schedule, the shift in their sleep schedule. So we just had to work together to find, well, what was the primary diagnosis that they were going to treat? What was the primary
Mm-hmm.
diagnosis that I was going to treat? And how did we configure this team around this person? And again, it comes back to communication. It's not the patient population that's the problem. It's the fact that we cannot seem to pull ourselves out of our practice and we feel like we have to do it all. And that's not oncology PT. That's not the field of
Mm-hmm.
oncology.
Mm-hmm.
Oncologists have such a vast team, and when you're a part of their grand rounds, everyone has a role. And we, as
Mm-hmm.
physical and occupational therapists, need to start using each other in our various disciplines and be able to share this load, because there's not enough oncology trained physical therapists. We know that. So let's pull
No.
in our orthopedic colleagues, our cardiopulmonary colleagues, if appropriate, our pediatric colleagues, if appropriate, if that person does have a newborn and now they are going to have care for their newborn, or just managing those aspects of their newborn care as well as their own cancer treatment and postpartum recovery. We need to be able to make sure that we are developing a team that that person feels is wraparound care for themselves.
As I mentioned previously, that is an excerpt from the interview that I did with Dr. Rebecca Seagraves in episode 271. You can find that full interview again at the oncopt.com/271. I have also linked all of the episodes we referenced today in the show notes, so definitely check those out. You can find that on the oncopt.com for this particular blog post. Now, another amazing physical therapist that we definitely needed to have on this particular collab mashup episode is another Rebecca, which is kind of fun. I feel like Rebecca's just a power name apparently on this podcast. Now, Dr. Rebecca Griffiths, who you may know online as the EDDPT, specializes in physical therapy in the emergency department. And again, I'm not going to lie, when I first heard about this, I was like, what the heck could this do with OncoPT? Hopefully nothing. But then I kind of sat with it. And I cannot tell you how many patients I've had who were first diagnosed in the emergency department. And I'm sure that's probably the case in your own experience, or if it hasn't been yet, it probably will be shortly. But it's a great episode to include in this mashup episode that we're doing today, because it does require so much active collaboration and true team work, which again, I feel like that's another kind of loaded buzz phrase. It truly takes the entire village to make the emergency department run. And one of the coolest things that I have learned from Dr. Rebecca Griffith since the time getting to know her and, have her on the podcast is just how much of a difference that they're seeing in how effectively and efficiently the emergency department is run, aka PT does not slow down the emergency department, but it's also changing the downstream effects of this. And one of the things we talked about in this episode, and I don't think I actually included it in this clip, so sorry if that's the case, go back and listen to her interview. That's episode 239. But one of the things she mentioned is that the emergency department is kind of like America's healthcare safety net. Probably not kind of, it is America's healthcare safety net. And so if she can be, or you and me as physical therapists can be part of that safety net to make sure that patients stop falling through the cracks, because we do know patients will end up in the emergency department at some point. It is very possible. Rebecca's episode really shows us what it means to be a part of this team and to work really well together. And I know you're going to love this clip. Take a listen.
When you think about those studies that show early access to physical therapy can save $2,700 per episode of low back pain, think about that. If you hurt yourself 20 minutes ago and you came in by ambulance, and I can tell you right now, it's safe for you to start moving. I've saved you missed time from work. I've saved you some anxiety. I've empowered you on what to do next, and I've connected you to early access physical therapy follow-up. So not just reduced hospital admissions, also like our patients who we're sending directly to subacute rehab because they're really not thriving at home. Hopefully that patient now missed a debilitating fall. They missed having a subdural. They missed like being found down in their home. Hopefully those are all things that were making a big difference. And then sometimes I see patients who've waited so long to get care, or they have some kind of new neurologic diagnosis, or they've just experienced a massive trauma. If they don't need to sit in the hospital for 3 days and I can send them directly to acute rehab, I'm all for that, because then they're not exposed to other sick patients. They're not spending 3 days in bed. They're able to just get up, get going, and like skip that unnecessary step and get moving forward. And I think one of my biggest soapboxes is that our healthcare system is so downstream.
Absolutely.
And really, like, we're catching people as they fall off the waterfall, and we're missing a lot of them. A lot of them are just falling all the way down. And in the emergency department particularly, we're like at the bottom of the waterfall. But if we as physical therapists in the emergency department can get upstream a little bit and keep some of these patients from going off the cliff, that is a worthy effort. That is absolutely worthy of our time and our effort, especially as we think about our vision and mission to like transform society. So we need to be where society needs us.
Mm-hmm. Can we talk a little bit more about the quality initiative that you did? And I'm going to bring that full circle here in a bit, but I think a lot of therapists, even in oncology, and I think this is where we can really take a page out of Rebecca's book here, is we know there's a need. We know that in general, and I say this like we as a society, we as healthcare administrators, we understand there's a benefit, but sometimes the connection of how this benefits the patients, the community, and also the bottom line is not well connected. And sometimes like our very outpatient ortho mill model drives whether or not cancer rehab is implemented well into like just healthcare period. And I bring this up because I think we have a lot to learn from what you did with the quality initiative. So can you talk us through this a little bit, please?
For sure. And I think the biggest thing is solving a problem that's not just rehab based, and solving a problem that isn't just focused on the patient. And I know that sounds like counterintuitive, because all we want to do is give people the best rehab that we can and solve everything we can for the patient. But in order to do that, we need to also solve some issues within our healthcare system, because if it's not easy to implement and it's not sustainable, it doesn't matter if it benefits the patient. If it doesn't work, it doesn't work.
Right.
Like if you're a morning person and you can only work out at 10 o'clock at night, like that's not sustainable. You're never going to do it. So you need to think of a way to do it in a way that's sustainable and works for everybody, because we aren't in silos. And I think that's a big mistake we see with people trying to do quality improvement, is that I'm going to do this thing that's going to benefit these people in this way. But you have to look at the context that you're in. So for us, in order for this to really work, we had to be able to look at all of the invested parties. And that included the emergency department. Like, what are their goals? What are their pain points? How do we, as physical therapists, the services that we offer, alleviate some of the pain points in the emergency department? And one of that is freeing up the physicians to focus on other needs. One of that is reducing the need for imaging. Another is streamlining the discharge process so that patients aren't getting held up in observation for 48 hours to get to subacute rehab. Mm-hmm. So those are all things that we can address. So you have to present that case like, these are problems that I see that you have. These are solutions that I can offer. Mm-hmm. And these are metrics that I know that are important to you. And here's how I can support that. It's good to have a team of invested parties that can help you anticipate what pushback might be. Mm-hmm. So, for example, one of the things they look at very closely in the emergency department is throughput time. Is having a PT consult going to slow us down? That's something that we really had to look at. Are we slowing them down? Are we speeding them up? And I think in some cases it goes both ways. Mm-hmm. But overall, physical therapy does save time and effort and improve throughput in the emergency department. So those were all really important things. And then really understanding, like, can I actually provide value to the patient in this setting? And how am I going to do that? That was the easy part for sure. And then can I support the physical therapists that are doing this work so that they're not burned out, they're not stressed, they're happy with what they're doing, and they're really able to use their clinical skills. So looking at kind of all of the different shareholders and making sure that you had people represented on a team and you weren't trying to do it alone. Mm-hmm. And then I think the most important thing is really looking at making a solid business case mm-hmm. with objectives that are attainable and following up on that regularly. And at the end, you may have not met those objectives and may have found different objectives, but it's good to know what your end goal is so you can work towards that. Yeah. We just did a second kind of pilot program quality improvement initiative in January of, was that last year? February of last year. It's been like a year. Where we put a PT in our fast track area, which is people who are there for like minor things. Okay. But a lot of that's musculoskeletal. A ton of that is musculoskeletal. Mm-hmm. So we just parked a PT right there to have them help manage those patients. And we some of the metrics that we looked at were how much time we were taking, because that area needs to move fast. Right. And we were looking at who we were serving. Were we really able to provide physical therapist services to patient population who would otherwise never be able to access it? We looked at patient satisfaction. Were patients happy with this? Because the emergency department is a very hard place to satisfy patients. but we were getting like 4.89 out of 5 on our patient satisfaction scale. So what kinds of things could we do? When did we need to partner with our APPs? When were we able to manage these patients independently? Was any harm being caused? What kinds of tests and imaging were we looking for that we needed? You know, things like that. And so understanding what everybody was looking for was very helpful. And I think if you're trying to implement something in this situation, a pre and post survey is also very helpful to find out about your like co-partner satisfaction with the work that you've done.
Yeah. So fast forward now, because this was about 7 years ago that this was first implemented. Excuse me. You've now have multiple therapists who are working this. So clearly, like the program has grown, but in what ways has the program like really solidified its place within the emergency department now?
I think we're just we're part of the culture, and I think to a certain extent we're part of something they advertise to staff when they are like to physicians when they're recruiting, like, hey, did you know we have physical therapists in the emergency department? We are helping with research about physical therapy in the emergency department. We are also really when the hospital right now particularly is looking at bedlock and throughput issues because there are so many patients and so few resources. They are looking to what can be done to make this better. And so the reason we've kind of upped to 3 people is one for that fast track area. How can we help turn these patients out and keep them from coming back? That's key in that area. If you get an x-ray and send somebody out with a severe ankle sprain and you tell them to come back if it keeps hurting, they're going to come right back. Right. If you give them education on how to self-manage that and refer them to a physical therapist, they're not coming back. Then in our main emergency department, how can we clear up space to get these patients moving out as quickly as possible? And then we've got all those patients that are holding in the emergency department because there are no beds upstairs. So those are patients that a physical therapist would see on the floor, but they're not on the floor. So do we wait 72 hours till they get a bed? Or do we have that third physical therapist start working with those patients to expedite discharge plans to see if we can discharge patients from that emergency department setting, even if they're hospitalized? And what can we do to keep things moving? So I think that's part of how we've really solidified that. I think provider satisfaction is huge. Like the physicians and the APPs are thrilled that they can call on our resources. I chatted a physician the other day with a teenager with knee pain, and I just wrote, hey, did you need a musculoskeletal expert? And he's like, yes, always, please come now. So like, I think that provider satisfaction is high. And then just really being able to keep the patients very well satisfied. All of those things really cemented our place where we are.
Now, you may be wondering, okay, so I've heard from these different physical therapists who are kind of outside but very adjacent to oncology. What about some of the like PT coworkers or colleagues that I might be trying to work with or trying to develop a relationship as I'm working with oncology patients? So I turned to the interview I did with Mari Galley from episode 275. Now, Mari is an oncology acupuncturist based out of Austin, and I love having her on because we always have so much goodness to talk about. But one of the things that I really loved is she broke down in this episode not only like what acupuncture can do for patients, but also how she works with the physical therapist in her facility on these different impairments that we're going to be talking about in this clip. So not only is it what acupuncture does, how does it actually work in the real world when you are working with another professional like Mari is talking about with her fellow physical therapist colleague? So amazing. If you're someone like me who really likes very visible, tangible demonstrations of a point here, this is exactly what you need, friend.
Definitely. So a lot of right now, if you're in active treatment, I see a lot of nausea and digestive issues like diarrhea, constipation, nausea and vomiting are huge. Also anxiety. There's also anticipatory anxiety that comes along every week when you know what's about to come with the next chemo round. Yeah. So I'll see a lot of patients the day before or day of cancer treatment. And then a few days after, which we can help with that awful steroid crash that happens, the fatigue and everything. Acupuncture is great for leveling that out. Neuropathy, hot flashes, bone and joint pain that are from some of the meds that patients are on, as well as like mental clarity, mental mind fogginess issues. Acupuncture is great for that. And then we're also good with just working in collaboration with PTs. So I see a lot of patients for neuropathy, but I'll have them get PT right before or right after. Um,
Mm-hmm.
and I think working in combination with other practitioners, it's a great thing. Something lymphedema, which we see a lot in the OncoPT world.
Yeah.
Acupuncture is a wonderful like adjunctive therapy, but it is not as the main therapy as it is with OncoPT or
Mm-hmm.
lymphedema rehab. So we're great in supplementing that, but the other symptoms, standalone acupuncture can help. Acupressure that I teach my patients at home, points that they can do, but always, working together is better than working alone, I think. So I
Mm-hmm.
work with a lot of massage therapists and PTs um, when working on many of the symptoms that we see.
Yeah. And I love the example of, like, I mentioned previously, I think CIPN is such a big area that I'm starting to see more acupuncture being used in
Yeah,
addition to some of the other, the pain and the anxiety that our patients face. That makes a lot of sense to me, but it really excites me to see acupuncture and neuropathy like kind of folding in, because I know for
yeah,
me CIPN can be really challenging to treat, especially when I can work on some of, especially like the compensatory strategies, like
right,
the balance and the
right,
falls and whatnot, but I am not always super equipped and able to handle some of the pain that my patients experience. And so that's
right.
where I think this is like a super big area to really fold into
Yeah.
working with our patients.
Absolutely. I think that it helps. So I usually see like the physical therapist I work with, I'll treat the CIPN patient first and we'll get the pain down and then they can go and work on
Mm-hmm.
their gait or whatever balance
Oh
issues
my
that
God.
the PT is working with. And then they can go home and rest or do whatever homework that we give them. But
Mm-hmm.
it definitely, I think the improvements start to be seen much quicker if they're using both. Yeah.
Yeah. Okay. Now,
Yeah.
you and I were laughing off air
Yes.
because one of my first experiences working with an acupuncturist in my area, so oncology, acupuncture, my patient came to me, and this could have been the patient, maybe the message wasn't
Yeah.
correctly encoded right, or maybe this is what
Or
the
maybe
patient was
not.
actually told,
Yeah.
but the patient came to me immediately after seeing the acupuncturist and said, I was told I cannot participate in rehab for like 12
Right.
hours after receiving the acupuncture. And my brain immediately went,
What in
we're
the world?
scheduled right now to see each other. Like,
Yeah.
what the heck?
Yes. Yeah, that's not really something I worry too much about. I worry more of like someone going off and, like we said, doing CrossFit right after, which
Right,
I think PTs
right.
would be concerned with as well. If you're just finally getting their back strengthened, or
Right.
whatever else they're working on. So that's not an issue. I think working in collaboration with PTs, massage therapists, personal trainers is great. It's just as
Mm-hmm.
long as everyone is communicating. And I think that's one thing that I feel like every ancillary practitioner or provider, different providers have to work on is like communication. So that acupuncturist probably should have like connected with you, especially because y'all were in the same um, department at that time, or he or she was working within your space.
Right. And
Yeah.
I should have reached out too, as far as
Now.
like, okay, I need some clarification, whatever.
Right.
So, what
Mm,
are maybe some guidelines or good kind of standard practices when it comes to,
yeah.
okay, my patient is seeing both me and the acupuncturist. How can we work best together?
Totally. I love, I know with the physical therapist I work with, we share notes back and forth all the time.
Nice.
So we'll pop in or even tell each other, okay, I just saw XYZ. This is what we're working on. Um, do this, this, and this. I think that for acupuncturists, for us, it's always really important for us to like stay in our lane of what we can do and know what we can't do.
Yeah,
Um,
totally.
and that's the thing I think maybe in different fields like chiropractic care, acupuncture, sometimes we always make sure that we know our limitations.
Right.
So working alongside PTs has always been helpful of me sharing maybe evidence-based research with the PT I work with about
Yeah.
this is what I'm doing and this is why, and this is what's safe and this is what is not safe in the oncology world. There are a few things that we do want to be careful of just with our patients. If someone's platelet count is way too low, anything below 20, then we are not doing acupuncture,
Okay.
just because we don't want to have any major side effects with that. Otherwise, if their white blood cell count is below 1, we don't do acupuncture because of risk of infection. It's very, very
Mm-hmm.
low, but why take the risk?
Of course.
So my patients know that. The practitioners that I work alongside with know that as well. So I really just think like that open communication and knowing what we both can do and what we can't do.
Mm-hmm. It seems like if a patient goes from PT to acupuncture, that seems like it would be a pretty good transition.
Yeah.
When it comes to a patient doing acupuncture and then PT, are there any precautions or just general practices that me as the PT should be aware of when working with that patient immediately after acupuncture?
Not really in the oncology world, not so much. There are some times where acupuncture can lower blood pressure. So a patient coming from like a really relaxed, calm environment of acupuncture where their blood pressure might have been lowered, it's not ideal for them to like jump up and start moving really fast.
Absolutely.
So I always make sure that my patients are hydrated and have a little snack before they go into the PT room. But otherwise, there isn't a lot that they have to be mindful of. If there's been like cupping done or acupuncture work on one side, there's that idea that it does increase inflammation acutely, which is part of the healing process. So it's a good thing. But knowing that that's already been done, so when you're working on that part of the body, just being mindful of it.
Mm-hmm.
But
Yeah.
otherwise, the risks are pretty low and the side effects are pretty low. So physical therapists should feel safe to work alongside acupuncturists.
Now, what kind of cracks me up about each of these episodes that I have pulled from for today's mashup episode is that they all came from kind of the end of the year. Whether I knew it or not, it makes me laugh to think back on it. Whether I knew it or not, I think I was aware of just how big collaboration needed to be for my own private practice and in my own community. And so I find that what I'm seeing a lot of times in my own practice and in my own community directly influences what we talk about on the podcast. And this was honestly putting these clips together for this episode were a definite reminder of okay, I think I need to lean more into collaboration in my own practice so that I can expand the reach that I'm having in the community. Because unfortunately, as I've mentioned a couple times here on the podcast, my own geographic community has seen a lot of turnover and upheaval when it comes to cancer rehab services available in our community, to the point that these patients now don't even have a lot of options. Like, there might be 2 or 3 clinics in my area. And y'all, I live in a metropolitan area. Like, it is urban. We are not country. Like, we are not rural in any capacity. Although Fort Worth, like, yes, cowboys, cowboy boots, cowgirl hats, etc. Like, we're not rural. We are actually a destination of healthcare delivery for many surrounding communities, and yet we still don't have reliable, accessible, widespread community rehab services. So that has very much been on my mind for the past few months. And so I think it's very fitting that a lot of these episodes we're going over today did come from the last half of the year, because collaboration has been such a thing on my brain. Anyways, I don't know a better way to finish this episode on collaboration than with the Dr. Karen Wonders. Yeah, the Dr. Karen Wonders. Now, if you haven't heard from her, I highly encourage you. You got to get plugged into Maple Tree Cancer Alliance, my friend, because Karen Wonders was actually one of our speakers at the Cancer Rehab Community Conference, along with Rebecca Griffith, and really has just honed in on how can cancer rehab and physical therapy and other rehab disciplines work together with exercise oncology in our own communities. Because that's one of the biggest things that I've seen over my 5-year career, is that patients will finish with rehab and then we kind of just let them go and say, good luck. I hope things go well. When in fact, we really need to be building that bridge, that almost off ramp from rehab to community exercise participation. And if you're wondering, how the heck do I actually do this, Elise? This next clip is going to answer all that and more for you, my friend.
What I think is so exciting for us, you and me and the OncoPTs and the exercise oncologists,
Mm-hmm.
is this is an opportunity for us to now impact so many more lives. And that's
Yes.
why we got into this field into the first place. I believe this will open up doors for us with regards to insurance reimbursement, which, as you know, exercise oncology is not something that's covered.
Mm-hmm.
And so, for me and with Maple Tree, every time I start a new hospital partnership, I have to help raise the money. Usually it's going to foundations, requesting support,
Mm-hmm.
all that back and forth, where once this is standard of care, once this is reimbursed, we will have access to so many more
Oh
patients.
my God.
And so I believe this is just the beginning of really what we've been spending our lives trying to accomplish. It's exciting. It's an exciting time. We say at Maple Tree, we say we're preparing for the tsunami because we believe that there's a tsunami to come.
I don't love that because that obviously means there's a lot of people diagnosed with cancer. But that sentiment, Karen, it's like that rings really true for me. So in my geographical area alone, which first of all, Maple Tree is not here yet, and I'm just like begging you to
We're gonna
come.
have to get there.
We need to get there. Yeah, come on down. So in my geographic area, actually like in my city, 2 oncology rehab clinics have closed down in the last 2 months. And it was not for a lack of patients. Like in fact, the opposite. One of these clinics actually had a 3 to 4 month wait list
Mm.
and just overwhelming with patients. Like there is no lack, unfortunately, of patients with cancer in my area and the country over. Like I'm aware it's not just a me thing.
Hmm.
But it's so wild because we know that there are so many patients who are just waiting to
Hmm.
get in to get this help. And there's so many barriers behind that, right? And like we could there's not enough time in this podcast episode to go into those. My God, like it kind of gives me palpitations just thinking about them. But what an immense opportunity to really set the stage for, and I think we see this a lot in other areas of cancer, right? Like if we start it with breast,
Hmm.
we can then apply it to other patient populations. Do we
Hmm.
want to get to those other patient populations as fast as possible? Yes. Do
Hmm.
I want to be there yesterday? Yes. But I
Hmm.
think starting with breast in this capacity can lay a foundation that
Hmm.
is, again, like we can kind of start to iron out the kinks. You mentioned this previously with Australia and seen some of the challenges they're experiencing. We can iron out those kinks and then we can apply that to these other patient populations in the future, which is really, really cool.
Hmm. Yeah, absolutely. Absolutely. And I think you're right. I don't think the trouble is getting the patients. I mean, I do think that is something we do need to focus on is how do we change that narrative for the patient to understand that this is a good thing. This is going to help you. We meet you where you are. We help you to progress from there. We're not going to make you do something that you're not ready for. Like, we're not going to expect
Mm-hmm.
you to run a marathon or
Right.
do anything like that. So I think that's an important narrative to have. I think it's important to be talking to oncologists and making sure they understand, at least from my point of view, and I understand your audience is a lot of physical therapy
Mm-hmm.
people, but with exercise, sometimes there's questioning of our credentials and are
Mm-hmm.
people credentialed to do this work. And so we have to spend a lot of time educating oncologists and doctors
Mm-hmm.
and nurses about this is the background, this is the certification they have. And
Mm-hmm.
while we're doing that, I think we need to be building a workforce so that when this comes, which we believe will come, I mean, I think we're probably 3 to 5 years away from
Yeah.
this being standard of care for everyone. We need to build that workforce. We're going to need a
Mm-hmm.
lot of exercise professionals and onco trained physical therapists. So it's a big lift all the way around.
I'm not that closely in the exercise physiology world, right? The exercise oncology. I'm very adjacent to it. But I'm curious, Karen, because I can already hear because of the conversations that I follow on Twitter, like I know someone's already thinking this. I know someone is like, well, if 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 exercise, exercise oncology people have access to these patients, then they're not going to come in for rehab.
Mm.
Meanwhile, you and I know that is so far from the truth, because again, literally, like, there are two clinics who shut down in my area. One of them had a 3 to 4 month wait list. There's another currently open practice in my area. Again, 3 to 4 month wait list. And then there's just no one else to treat these patients. So it's not that they're not there. Like, they are there, and they are
Right.
just begging for the help. And so can we spend a little bit of time debunking this very common but problematic myth?
Yes, 1,000%. And I will say, I feel like the conversations I've had, at least over the last couple of years, we're starting to drift away from that narrative, but I know that
Good.
it still exists.
Good.
And so I can tell you what we have found to work for us at Maple Tree, because there are many of our clinical partnerships where we're working side by side with the skilled service
Mm-hmm.
line. And
Yeah.
so what we utilize is there is a triage tool that was developed by Dr. Kelly Covington Wood, who is a physical therapist in this space. The name of this triage tool is the Exceeds questionnaire. And that has been validated in an oncology population. So any patient who comes to us fills out this triage tool. And
Mm-hmm.
essentially, this triage tool is like red light, yellow light, green light. So red light, patient gets referred straight out to physical therapy because they're
Mm-hmm.
going to have something that is beyond our skill set. They need to be with someone who is trained to work with that.
Right.
So we refer out.
Absolutely.
I'll tell you, 43% of the time when a patient comes to Maple Tree, we refer them directly to physical therapy. So
Mm-hmm.
we've been able to drive
There you go.
referrals to PT.
There you
Um,
go.
Yellow light is it's safe for this person to do supervised exercise training, which is what we do at Maple Tree. That encompasses about another 45% of the patients that we see. And then that little box, that green light box, that means it's safe for this person to exercise unsupervised in the community. That's usually a small portion of our patients that are free to go into community-based settings, but
Mm-hmm.
once they complete their active treatment, we can refer them out. And so when we do that, when we refer out to physical therapy, what we try to do is just to establish these lines of communication, because in most cases, not most cases, 30% of the time, we can, so of the 43% that we refer to PT, 30% of those patients can do exercise in parallel with the PT. And so
Nice.
we just work side
Very
by
nice.
side with them. PT works on that very specialized function, and then exercise is a little bit more whole body approach. But we're working together and we're communicating back and forth. And that to me is how the patient is going to do the best in that type of environment where everybody has the highest and best use of their degree. We have open lines of communication. We're not afraid someone's going to steal the patient from us because, as you said, there's more than enough patients to go around. What we need are
Mm-hmm.
workers. And so when you can establish those clear channels of communication and the patient journey, I think that is the best overall way for the patients to be able to thrive. And if you look at other disease states have been doing this. It's cancer that needs to catch up. I mean, you see this with knee replacements all the time. They go from PT to exercise, and then they go from there to the real world. And you see that in other illnesses. And so I think it's high time that cancer has caught up to the rest of the world, I think.
I 100% agree with that. Like, neither one of us have a monopoly on oncology patients. Like, there are more than enough to go around. And
Hmm.
Karen, I feel like you're living in I feel like you're living in the year 2030, because what you said, and I really want to call this like back to the front, is we need a workforce
Hmm.
of people who are prepared to treat this patient population. And I know
Hmm.
there's a ton of conversation. I feel like there's always a conversation going on about, like, the market is oversaturated. Like, we have too many new grads and not enough jobs. That has not
Hmm.
been my experience at all,
Hmm.
especially in cancer. Now, maybe
Hmm.
other areas, yes. But my gosh, y'all, like, there should not be any wait list when it comes to oncology patients. And we are
Hmm.
just inundated with that. And I really do. Like, I think this is so much more big picture. Like, we really have to zoom out and look at this big picture wise, because
Mhm.
what is happening right now, and even what's going to happen like next year,
Mhm.
needs to be firmly focused on
Mhm.
how are we going to make this the best it can be for when it is standard of care in
Mhm.
5 to 10 years or whatever that is, right?
Mhm. Yeah. And if you do the math, there's 2 million diagnoses every year. When this is standard of care, when this is paid for, my estimate is, can we get half of those people exercising? So 1 million people, 1 million new diagnoses every year. The exercise physiologists that we'll need, the number of exercise trained oncology professionals we're going to need is 20,000 to meet that demand. If we have 1 million people going through 12 weeks of an exercise program, that doesn't include PT. PT is going to be probably more than that.
Yeah.
And that's just the newly diagnosed people. There are 20 million cancer survivors out there that are dealing with the long-term and late effects of cancer and their treatments.
Right.
And so this becomes a big problem when you kind of step back and you think, right now in the US, I think there's maybe 1,500 certified exercise oncology professionals. I think that was the number we had the last time I looked.
Wow.
Not
Wow.
enough. We
Wow.
need to develop a workforce. We really do. That's honestly why I still continue to work as a university professor, because I'm trying to do that through my university. Because I keep thinking, I don't want to work so hard to get this standard of care and then it to fall apart because we don't have enough
Right.
workers.
Once again, thank you to each of the amazing speakers that came on the OncoPT podcast earlier this year and are continuing to teach me such amazing information on how I can build my own practice and be a better advocate for patients in my own community. And I hope that you have learned a lot from this episode as well. As I mentioned previously, I have linked all of the speakers and their corresponding interviews to the show notes for this particular episode. You can find that at theoncopt.com. You can also click the link inside your podcast player now to find that, and I highly encourage you to check that out. Until next time, this is Elise with the OncoPT. And remember, you are exactly the physical therapist that your patients with cancer need. So let's get to work.